and erythromycin. So in our hands, if you have evidence of no cirrhosis, no portal hypertension, so patients who are potentially surgical. So you talk to your surgeon, he tells you if this tumor is smaller, I will resect it. So they have no portal hypertension, no cirrhosis, then chemotherapy plays a big role there. So 33% was the resection rate in this study in particular. I know that most of your patients have cirrhosis, but with the new hepatitis C treatments, I think you're going to see more and more patients looking more like Hep B, which we have cancer without cirrhosis because you clear their virus. So, but I think you have to start now to propose those studies future-wise, working with your hepatologist in a multidisciplinary manner to study those patients who clear their virus, incidence of HCC in them, incidence of cirrhosis when they develop HCC, and then randomize them to no cirrhosis, they get chemotherapy because it's much cheaper, better for your environment, and you have to modify the algorithm based on your own resources. So you cannot rely on Avastin off protocol because Avastin off protocol is very expensive for patients in Egypt. So while this could be okay in Saudi Arabia because Avastin is covered there, and your rationale here to use chemotherapy is much higher, but to do it in a study kind of manner. So you have your IRB, you have your committee approving this for you, and they have parameters for the cirrhosis. So our parameters to define cirrhosis is or not is bilirubin less than 1, platelets above 100,000, and no varices. So these three, if they fulfill them, then we go for chemotherapy.
Any further questions? Oh my goodness.
Thank you, Ahmed. Very good, interesting topic. You know, the majority of our patients in Saudi Arabia actually are child B and C. Only the minority are child A. So two questions. First, do you offer sorafenib to child B? And also, just similar to Dr. Hebazawari question, you're aware of the FOLFOX trial, the Asian trial that showed survival advantage in patients with hepatocellular carcinoma, upfront therapy. Are you aware of any further studies to either replicate this, see if they really FOLFOX does give a survival advantage? That was FOLFOX compared to doxorubicin.
Yeah, so two good questions. So the first one, which is child PUB. So we published a study at JNCI looking into the IGF score, and interestingly, within the child PUB, there was about 15% of patients who moved from child PUB to new class A. So those are the patients that you see them, and a year later they're still coming back, and their cirrhosis is the same, and their tumor is less indolent. So in general, we do it for patients without massive ascites. So child PUB is very heterogeneous, right? So you could see somebody with massive ascites and bilirubin of 5 and that child PUB, and you could see somebody with child PUB because the only thing is the albumin of 2.5, but everything else is normal. So it's a very heterogeneous population. So in general, if they don't have ascites or controlled ascites, if they are child PUB because of just malnutrition, and then I start sorafenib at a lower dose, just 400 daily, and then in a week I see them again. Half of them, the child PU will advance, and you will see bilirubin going up to 5 or 6, then we stop. But half of them would have good, reasonable bilirubin level, and we continue. So I have a bunch of patients on sorafenib low dose, just 400 daily. That's all they can handle. And I think the key is to, with our international study for the biomarkers, is to show that their actual score is IGFA, so they're B, but this is a good B rather than the poor B. So we need to collaborate in this area. The second point with the FOLFOX, I do it also for patients without cirrhosis. So they fail PF, I switch them to FOLFOX. But you have to really make sure they don't have varices, and so you do EGD and all of that, because we all know, and you guys know better, the colorectal studies showing the oxaliplatin effect, sinusoidal injury, and then portal hypertension. So you have to be very careful. If they have evidence of portal hypertension, I never do oxaliplatin.
Yes, sir.
Dr. Ahmed says that the role of hepatitis B virus in developing HCC is depend on the integration of HB virus in the genome of the hepatocyte. We can how we can assess the role of hepatitis B virus treatment in patient with ablated HCC to prevent the recurrence of HCC.
So the pathogenesis in hepatitis B associated HCC is multifactorial still. So the integration of the DNA is one mechanism, but you also have to understand that also they could have cirrhosis, and when they have cirrhosis, they have a lot of other pathways involved. They also have angiogenesis cascade and so on. So the mutation based on the integration of the DNA is partially responsible for the pathogenesis, but all the other risk factors, so a lot of them will have NASH, a lot of them would still have cirrhosis, and the angiogenesis cascade would be very activated. The hepatitis B X protein overexpresses the VEGF, also interacts with the androgen receptor, so that's why you see men patients, they have more aggressive disease. In Asia, it's mainly male predominant disease, almost 90%. So the story is much bigger than just integration of the DNA, but the integration of the DNA story is the rationale to screen them for life. So even if they don't have cirrhosis, even if they don't have NASH-related, concomitant risk factors, I think they're still at risk. So you use this to screen them, but for treatment, you still have to do the molecular profiling.
I would like to thank our distinguished guests, and I would like definitely there are so many questions to be answered concerning the HCC. We need to fine-tune the staging systems. I believe that in Egypt we are witnessing an era with the introduction of management of hepatitis C, which deserves a national campaign for long-term surveillance for the development of HCC. Thank you so much, and we close this session.